Now, I think we'll invite our next speaker. We have a little change in lineup of talks. Dr. Arvind, he has to attend another session going on at same time. So over to you, Dr. Arvind. Will not.
Good morning, everyone, and thank you, AIOS, and especially Professor Manisha Nada for giving me this opportunity to be a part of this wonderful session. So my talk is on triple premium IOL selection in a patient of mild non-proliferative type of diabetic retinopathy. So this was a 45-year-old diabetic patient, well-controlled blood sugar levels with glycoside well-controlled, intermittent cataract, wants no spectacles after surgery, and he is a 10-meter air pistol shooter and loves driving. He has a mild NPDR with very healthy macula and normal range IOL power with no astigmatism. So which IOL to choose? Okay. So for the intermittent type of cataract, we have developed this technique of sieving needle microcapsulotomy. So this is how it is done. A small bent needle is used. So it is giving a microcapsular access, and this liquefied cortex comes out as a volcanic eruption. Now you can see it's a round regular margin, because cystitome, it has irregular margin and gives a linear cut. And then we are able to make the intended 5 to 5.5 millimeter of rhexis quite easily. So which IOL premium IOL to choose that corrects all types of vision, no dysphotopsia, no glare or halos, because patient loves driving and he is a shooter. So the 10-meter air pistol, they have very small bullets. So the patient needs very good intermediate as well as near vision also. And so it needs to be pupillary independent also. So this is the answer to all the problems, that is Autofocus Pro. It looks almost like monofocal, but it works like multifocal. So it is an aspheric polyfocal progressive lens without any diffractive rings, static and fixed in the bag, and there is no mechanical pseudo accommodation, yet it functions like a autofocus lens as the name given. It is a progressive type of IOL as seen. And this is the size of the design of the this Autofocus Pro. So this is the design of the Autofocus Pro. So the L loop with zigzag outer edge and square edge prevents any PCO, and 360 degree amon apple posterior square edge there, polyfocal progressive optic, and the size of this is 13.0 millimeter. With the optic size of 7.5 millimeter, so there are no chances of dysphotopsia.
This is the schematic diagram of autofocus progressive polyfocal optic,
please,
which gives.
So there is excellent DIN vision, distance, intermediate, near, by GRIN technology, that is gradient refractive index, and there is no loss of light energy. So these are the different zones for distance, intermediate, and near. And there is no light energy loss because there is no destructive interference or diffraction, and angle kappa or angle alpha are of no significance value. MTF is very good. The highest MTF is better. The ideal MTF is 100%, but it is not possible to achieve. And most of the monofocal IOL, they have 70 to 80% of MTF, and most ringed bifocal and trifocal have 30 to 40. So the image is misty, blurry, waxy, and contrast is low. Whereas Autofocus Pro, although being a progressive multifocal, has multifocal value around 70%. So thus IQ at retina and contrast are as good as a monofocal IOL. And there is no optical noise, so there is almost no neuroadaptation is required. And one eye Autofocus Pro and other eye ring bifocal, so this was the difference in the vision quality. It was waxy, misty vision, whereas it was free, crisp, sharp vision in case of Autofocus Pro. And out of more than 5,000 implanted, not a single patient complained of negative dysphotopsia, because dysphotopsia is because of this space, right? And in diabetes, of course, with healthy macula, we can implant this lens without hesitation because there is no double or triple diffraction of green laser spot. If at all, they need PRP in future. And larger size of IOL optic body is also a good advantage for retina surgeons. And this is a difference in the night vision with the trifocal, and with the other side is the autofocus pro. So it can be implanted in night drivers also. Anyone who is fit for progressive spectacles is fit for this IOL. And my acknowledgement to the inventor of this wonderful IOL, Dr. Jagdeep M. Kakadia and Dr. Ramesh Shah. Thank you so very much.
Thank you, Dr. Arvind. I think this lens is specifically not made only for diabetes. It can be used for anybody.
Yeah, definitely.
And this is
very cost effective.
Commercially available?
Yeah, it is commercially available.
Okay.
Yeah.
And how many cases you have done with?
I have done 23 cases.
Okay.
Yeah.
And
contrast sensitivity with this?
Yeah, it's very good. It's very good. Yeah, clinical trial is going on, but we have done, the sample size is 153. We have done only 20 cases, so it's too early to be conclusive. So just wait for a few months, then we will share the results.
I think excellent. But just a question, I think not less scientific and then less ophthalmic. How could you capture those two set of photographs through IOLs? Like, or was they are just representative photographs, images?
Yeah. As the patient says.
Okay, it's based on their descriptions.
Yeah.
Okay.
Based on this.
No, I thought maybe we have a technology to do that.
No.
If we can put it over SLR or something, and to see actual difference.
It's a very good suggestion, and we will think about it. If it can be done, it can be attached to the mobile camera and can be taken. So we will definitely go for
This
it.
has been done actually. This has been reported.
Okay.
Putting IOL on a mobile phone's camera and recording pictures through that. But that much. No, that was, I think they did to capture retinal images and all those things, but they were not evaluating IOL performance through this technique. Yeah. But I think real life experience through that different IOLs, that would be interesting. That keep telling them, these premium IOL people, that you should do more real life studies. Let them walk. Yeah. Yeah.
But at low light conditions, I realized that because of everything is not able to see, while in good lighting conditions, everything was good. So what when they say in multifocals that it is 98% contrast, that 2% is there in the low light conditions. So they do not appreciate the difference. But as you said, it's a good food for thought.
Yeah. Yeah, we are doing a clinical trial, first such clinical trial. So it's too early to say or comment. So I won't.
even Vivity also gives halos and glare while night driving to so many patients.
So there are diffractive zones, no, sir? But
just another EDOF lens.
Yeah.
The company in fact doesn't promote it much. They say the first option of their concept is this particular company that you go for their trifocals as a product.
Yeah.
And because all this like competition is coming up with this thing, they're promoting those sort of habit. So none of these are perfect. So counseling is the most important thing. The whole trick is in counseling the patient in that channel.
So can we use these lenses in children also?
yeah. Why not? If the astigmatism is less than 1, we can go for this level. Because they are not available in toric variant.
Patients come now where there's a weakness of the news, accommodation is not there.
No, it's not. Even we have put in a traumatic mydriasis patient and very good distant, intermediate and near vision.
I think, but the
So
main selling point would be to test them on patients with macular pathologies, who are prone to have much more impact on contrast and all.
Yes, we applied for that, but ICMR rejected that already this is unhealthy, so they won't permit us. ICMR rejected our proposal. We tried for that. So maybe later on we will again try and submit our proposal.
In general, a word of caution, not just any multifocal, trifocal, any lens which is serving more than one focality. One has to have a word, there should be a note of caution and the patient should be counseled.
Yeah, but it's more like a monofocal. There are no diffractive.
That's what they say about readout, that's what they say about enhanced.
Yeah.
Even all there also, because the light is, whenever you play around with optics, there would be a compromise. So what I tell my patients, these are all compromised lenses. That's the term I use. You are getting increased enhanced functionality, but at a certain compromise. So these are compromised lenses. Get it drilled into their head. Make them be responsible for their decision. You know, because then it's easier for them to live with it.
Yeah, counseling is very, very important. Yeah,
Yeah. These are compromised lenses.
Absolutely. Same. We also
To say that and they take a conscious decision. I recently had a patient. He's a very well educated, very smart person. And then this guy, he was considering various lens companies and finally comes to between Vivity and Panoptic's. So I had to tell him about all the pros and cons. Turned out to be a good result, but of course,
but night issues तो होता है.
because there's a little bit of dissatisfaction, but now he and his whole family knows that we went back and forth so much that the onus is on him. So what did he choose? He chose. I chose, right?
he chose.
He chose.
He only knows what he chose.
I can only guide you.
Yes.
The decision has to be yours. I'm never going to tell you.
That is the best thing to do, because if the patient is 100% ready and with all the cons and pros, then only these type of yeah.
And you know how they perform, you know how what just to make your ego and what city का क्या करना है, सब कुछ पता है.
Right. So
Patients are sensory system has to be a part of it.
Yeah.
It's a big variable.
I think
Absolutely.
in interest of time, we'll move on.
Thank you so very
But
much.
this is a very exciting discussion.
Yeah, we can have a
Yeah, over
this